Thanks for joining us today on this fine Saturday in October. I'm SPF Tim. I just wanted to give you a couple of minutes to get logged on, get clicked on, get all that Zoom stuff going in the right direction, do all that good stuff you got to do in the background. But I did want to take just a couple of minutes and just talk about all the great things that we've been doing since this summer. And we started our virtual conference, virtual series that we've been doing. We had that great time with Awareness Week, which was a lot of fun. People got out, people got to meet people, we got to talk to people, we got to tell everybody about HSP and PLS and the Spastic Paraplegia Foundation. I know Tina and I had a great time. We got to do a little vacation this year and we got to get out, talk to a lot of people. We gave everybody a bunch of wristbands, to remind them about who we are and what we do. We also had the 5K, remember? We did that. Everybody got together. Got a nice shirt here that shows us about the 5K, the run, walk, and roll that we all participated with. Had a really, really great time, once again, getting out, giving some awareness to our situation and our members of what we do and what we're all about, and trying to spotlight HSP and PLS. So that was a fun time. I really enjoyed doing that. I must have done 4 or 5 different 5Ks throughout the whole summer. We were going all over the place, having a great time. We got a lot of family and a lot of friends participating with it. It was exciting and it was good. It was healthy. We got to get out and have some fun. Also, I wanted to remind everybody also about the fabulous SPF store. You can go to the website, click on the link, and you can get shirts just like this one, okay? With the SPF logo on it, kind of telling you and everybody about what we are and what we do. I give them away as gifts for the holidays and for birthdays and to friends. And anytime we get together, I'm always giving away a shirt to somebody, just once again to promote awareness and also just because they look good. They're high quality, they're great graphics, they look good. And there's really a cool new graphic out there now that you guys should check out. One that it's about Halloween. We are in October. We're a couple of weeks away from Halloween. It's getting a little cooler. You might think about getting the long sleeve shirts, okay, but getting the logos on there. So this is just a couple of things that we've been doing just in the last couple of months. Remember, Awareness Week, a 5K, SPF store, always good things. But now I have to officially begin our presentation today. So thanks for sticking with me for a couple of minutes. And I wanted to welcome everyone to the Spastic Paraplegia Foundation's 2021 virtual annual conference presentation. Today's event is the 6th in a series that we had scheduled over the summer and fall, highlighting the researchers who work with SPF to find a cure for HSP and PLS. We are using the Zoom webinar platform today, so we can't see or hear you, but we know that you are with us. Our guest speaker today will be answering some of your questions during his presentation, so you must use the Q&A box on the bottom of your Zoom screen to submit your questions. Please don't use the chat box, okay? Also, we are collecting your questions today, so if we don't get to all of them, our guest will try to answer them at a later date, okay? Please note that we are recording today's virtual conference presentation and it will be available on the SPF YouTube channel very soon. Okay? Now let's review. Type your questions in the Q&A box on the bottom of your Zoom screen and don't use the chat box. And also, we need you to stick around a little bit after the presentation is over today because we have a poll that we'd like for you guys to answer, okay? It'll pop up on your screens. Just click a couple of buttons, answer those poll questions. That helps us a lot. And we'll remind you about that a little bit later. Okay, everybody, here we go. It's time for me to introduce the president of the Spastic Paraplegia Foundation, Mr. Frank Davis. Frank?
Hello, everyone. It is my distinct pleasure today to have the honor of introducing Dr. Hiroshi Mitsumoto, PhD. One of the highlights of being on the board of directors, as all of us can tell you, of the Spastic Paraplegia Foundation is knowing about and learning about the process of science, research, and getting to know some of the primary people involved in that research of finding our cures. Some scientists, understandably, do it because they are furthering their careers and they want to make a name for themselves. Sometimes scientists do it because they love science and they're in their laboratory, they are like a kid in the candy store. Other scientists, like Dr. Mitsumoto, do it because they love people and want to help people who are suffering. I genuinely feel that Hiroshi is a genuinely good human being who works very hard to help others. Dr. Hiroshi Mitsumoto is the Wesley J. Howell Professor of Neurology at Columbia University at the Neurological Institute of New York and New York Presbyterian Hospital, Columbia University Medical Center. Previously, he was on the faculty of the Cleveland Clinic Foundation, where he served as director of the ALS/PLS Center. A graduate of Toho University of Medicine in Japan, he completed his internship at Baltimore City Hospital at Johns Hopkins University, residency training at neurology at Case Western Reserve, as well as neuromuscular fellowship training at Tufts New England Medical Center. Dr. Mitsumoto has devoted his clinical and research effort to the investigation of ALS in both animal models and clinical trials in patients with ALS. He is presently conducting an NIH study of disease markers in ALS. Dr. Mitsumoto has published and lectured nationally and internationally extensively on the topic of ALS. He served as a member of the steering committee of several clinical trials in ALS. He received the Donald C. Mulder Award for Achievement, Leadership, and Dedication in ALS from the ALS Association in 1996. In 1998, he became the 5th recipient of the Forbes Norris Award from the International Alliance of ALS/Motor Neuron Disease Associations for his, quote, compassion and love of humanity in the study, management, and support of ALS/motor neuron disease. And in 2000, he received the Lou Gehrig Memorial Award from the Muscular Dystrophy Association. He served as chair of the ALSA Medical Advisory Board until 1999, and now is a member of the MDA Medical Advisory Board, ALS Care Board of Directors, and Neurology Editorial Board. Dr. Mitsumoto was very instrumental in setting up the second International PLS Medical Conference in May of 2019. I attended that 2-day conference where a lot of very valuable conversations and talks about PLS took place, and many new PLS research projects were formed. I'm sure that Dr. Mitsumoto will be discussing some of that research with us today. Please join me in welcoming Dr. Hiroshi Mitsumoto, PhD.
Thank you very much for such a kind introduction. I really am glad and fantastic to talk to you with this virtual conference. Once again, thank you so much. So let me share my slides. I hope everything goes well. Right, okay. I'd like to move this away a little bit. So now we are talking about, we are making steady progress in clinical front of PLS. And, and today's topic, I'm going to talk about just a brief history of PLS. I talk about all clinical aspects of PLS and what do we know about the PLS, and also PLS Cosmos studies, which is a cohort study of multi-center oxidative stress for PLS, and also develop PLS-specific functional rating scale, and a proposal to RFA, which is a request for application from NINDS, which was failed, but learned so much, and a second international PLS conference, which just Frank mentioned, and the new PLS diagnostic criteria, and PLS natural history study, and also summary and conclusion I'd like to give, if I may. So brief history of PLS. 1865, Charcot is the father of neurology, described ALS. He also described hysterical attacks of limb contracture, sclerosis of lateral column, and atrophy of anterior roots, which turns out to be PLS. In those hysterical word, the word hysterical was commonly used when they do not know what's going on in those days. 1981, Bill and Richardson described PLS case, United States, and full autopsy studies. And then later that, several investigators described predominantly retrospective, that means the collective cases analyzed on PLS. 1992, Pringle, which is a famous doctor for working for this PLS, with Hudson and Gordon and Strong described the PLS and the diagnosis criteria by them. 2002, Spastic Paraplegia Foundation was established in the USA, which was so monumental progress. And then still PLS is one of the rarest and most obscure neurodegenerative diseases. So what to do with this? I cannot see this. I cannot move this away, sorry. Sorry, so bear with me, a little technology issues. So what do we know about the PLS? And incidence and prevalence is very rare. When we see 100 ALS patients, probably 1 or 2, perhaps 3 turns out to be PLS. When you look at the entire prevalence case in the United States, probably more or less 2,000 cases. And the cause and pathogenesis is unknown. Nosology is unsettled. Natural history is limited knowledge for long-term prognosis outcome. And clinical features variable, and the clinical description dominates the literature. And diagnosis still uncertain, particularly in early stages. And in terms of assessment, upper motor neuron scale and LSFRS yet to be tested in a real world. There are new scales developed, but not tested in real patients' situations. Neuroimaging is the most progressed in relationship to ALS to date. And neurophysiology is important for making diagnosis, also understanding of neurophysiology of upper motor neurons. Biomarkers are iffy at best, and genetics just beginning, and the clinical trials never done for this disease. So this is anatomy. And PLS attacks upper motor neurons. Upper motor neurons reside in the brain, in the motor cortex, and the tracks goes down and crossed at the medulla to go to spinal cord. This is the brain, if you can see, very thin, called the paper edge thin of the motor cortex because of atrophies. You can see, you can appreciate how thin the motor cortex. Then spinal cord, if you look at the cross section, this is the tracks going from upper motor neuron to lower motor neuron. And so you can see disease from upper motor neuron to tract, but not lower motor neuron. So ALS spectrum is actually lower motor neuron disease, lower motor neuron, upper motor neuron combination is ALS phenotype, but the pure upper motor neurons turns out to be PLS. But somehow pure upper motor neuron goes to ALS phenotype, and lower motor neuron phenotype goes to developing into ALS phenotype sometimes, not always. This is another way you can look at motor neuron develop so-called classical ALS. Certainly bulbar onset means the speech and swallowing remains to be bulbar problem, turns out to be progressive bulbar palsy. Lower motor neuron type turns out to be PMA, progressive muscular atrophy, and upper motor neuron onset sometimes just remains to be upper motor neuron we call PLS. So how clinical expression you can identify by clinical examination. Upper motor neuron syndrome is a loss of dexterity is impaired, and modest loss of muscle strength, spasticity, hyperreflexia, and pathological reflex, all those upper motor neurons. And lower motor neuron, on the other hand, muscle weakness, muscle atrophies, hypotonia, reflex is down, some fasciculation, muscle cramps. Those are lower motor neuron syndrome. You can identify by examining a patient. Some objective markers available, such as transcranial magnetic stimulation, neuroimaging technique, but EMG is the best technique to detect lower motor neuron dysfunction. So early 2000, and as I mentioned, 1990s and 2000, there are only 5 centers studied PLS retrospectively. They collected all their cases, analyzed what's the characteristic clinically. So there are only 5 centers, and we got together and received the PLS grant at that time, 2009, and studied PLS cohort study of multicenter oxidative stress PLS Cosmos studies. And you can see the beautiful flowers of Cosmos. And so we got a PLS comparing ALS, and the PLS is defined more definite PLS, and we decided to get more than 5 years from symptom onset. So 5 years later, we published a paper, phenotypic characterization of primary lateral sclerosis, and we got many studies. And the cases are divided into bulbar symptoms and urinary symptoms, and then just pure spasticity. Somehow we get the 2 groups, but at the same time, we found molecular abnormalities. So this is a conclusion of studies. The PLS is yellow, and the PLS is not the pure disease. Somehow overlap with the sporadic ALS, because the PLS becoming a little bit more ALS phenotype, and the familial ALS genes causing PLS, such as C9, ORF72, or dynactin mutations. Sometimes Parkinson's mutation causes PLS phenotype. And of course, most commonly, HSP is expressed as a PLS. So PLS is not a pure disease and somehow overlap. But if you can see, majority of PLS, 85% or more, are just the PLS phenotype alone. So we studied how disease progressed. This is the PLS, year 1, year 2, we followed the 2 years. ALS, we had a lot of case, and we looked at the disease duration, all those clinical features, and finger tapping, foot tapping, and also various changes, how they progress. I'm going to show you this slide once again. And then also we looked at the urinary biomarkers. PLS patient has a clearly urinary biomarker called isoprostene and 8-oxo-G, controlling with this arrest studies, this is ALS studies using the controls. Clearly, PLS patient had increased oxidative stress markers in urine, very, very significant, and probably close to significance to 8-oxo-D-guanosine. And these are DNA adducted product. I think these tests needs to be once again carried out in different ways using own controls. I think that's, we hope we can carry out these studies we are going to talk about later. Now, I am sure you heard LSFRS-R, means ALS Functional Rating Scale. If you go to ALS clinic, any clinic, ALS, we use LSFRS, the clinic, the clinical trials, anyone, everyone using, every center, all world using LSFRS, so common, was developed early 1990s, and this is a total scales 48. So common. That's the reason we had only LSFRS available by then. We used LSFRS, this study, just I showed you the slide seconds ago. And LSFRS, I can see the red, you can see the red letter, and the PLS is moving so slowly. Oops. But ALS is moving just a regular way, about 1.38, 1.4, a monthly progression. This is per month. But PLS is moving so slow. Let's say 30, almost 37 times less than the ALS progressions. First year 0.04, second year 0.17, slightly faster, but still significantly less than ALS. So I thought we can't use this such an insensitive scale to detect changes with PLS. We must have something else, more sensitive test. Yet LSFRS is so famous, so well established, everyone using this. So we wondered how we can increase sensitivities. We studied and we published 4 years later. This is primary lateral scale, PLS scale. And I'm going to show you PLSFRS. We added intermediary between, you can see between 4 and 3, just in between, and 3 to 2 in between. So increase sensitivity, I hope you follow. So total scales 68, but the 2 respiratory scale is original and did not added an intermediary score because not many people, essentially none of the people with PLS develop those respiratory problems. So we used up to R1 10 scales and then increased in sensitivity, adding to intermediary, and original language maintained. So total scale was 68 instead of 48. So we worked with 21 centers because PLS is a rare disease. You just cannot do the work with a few centers. We worked with 21 centers and contributed a patient for these studies. And then end result we got, this is PLSFRS, green one is LSFRS. The clearly numbers are higher, and maybe you have to imagine, but the slope is a little bit more on PLSFRS compared to LSFRS. And we noted clearly even 6 months, PLSFRS more sensitive than LSFRS with highly significant statistical changes. And at the 12 months point also you can see significant changes. Can you see arrow, I hope? And so clearly we demonstrated PLSFRS increased sensitivity than LSFRS. These are total score, means all patients available, but we had 70 patient, 77 patients, excuse me. Yet also, I cannot see the title, but this is early cases less than 2 years. We got those cases and we had only 10 cases, and the 6 months point, they did not show any difference, but the 12 months point, you can see the clear difference. So even early cases, you can see difference when you use PLSFRS score. So we got the now better scale, specifically evaluating disease progression of PLS. So now this PLSFRS got some interest in other people, and the French people already developing validation studies using French language in PLSFRS. By the way, LSFRS is translated almost all different languages. And so we hope we can change to PLSFRS in different languages, so French now, and Dutch now, and the Japanese. Professor Kano is doing now validation studies in Japan. Italy already did, and Leonardo van den Berg, Dutch studied. So I think it's now different languages are becoming available. So I thought perhaps we may ask NIH grant, because NIH grant support, indirect cost, and everything, high level of support. So I wondered whether we are good enough to apply NIH grant. At the same time, around that time, we got RFA, which is request for a application. NIH decide steer the research by funding. So the title was a clinical trial readiness for rare neurodegenerative diseases or neuromuscular diseases. So without any doubt, PLS is such a rare neuromuscular and neurodegenerative disease. And are we ready for clinical trials? So we decided to apply. So we got nearly 50 sites because we have to work with multi-site studies because this is so rare. We have maybe a few cases a year or more. So we need to work with multi-site place. So we applied this clinical trial readiness 2017, and they give comments, even approved or not approved, they give comments. And unfortunately, the grant was not approved, I have to admit. However, they said, Wes, PLS is rare, you're right, but proposal for clinical trials in PLS was still premature. Essentially, they said that you are not there yet. So no known pathogenic mechanisms, we don't know what's going on in PLS in terms of pathogenesis. How to diagnose PLS has not been established. Natural disease cause has not been established. No biomarkers. There are no medication for PLS to test. That's their comment, not approved. So they're right. And the PLS is still obscured disease, yet we learned how to cope, how to manage, and how to develop these questions. So their comment in terms of no known pathogenic mechanisms and the diagnosis of PLS has not been established. I'm repeating what they say. So we decided to get international meeting, and this was actually third or second large international meeting. About 75 people came 3 days. We had an intense meeting in Philadelphia University of Pennsylvania, and we used the museum of University of Pennsylvania, and the people drifted away to look at some exhibition. So we didn't have any entire 75 people to say the regret when I took pictures. But this is the case. We had multiple funding sources, and we're lucky to receive, of course, SPF and other NIH and all those funding agency supported this meeting because they realized that PLS has to receive more attention. So immediately after this meeting, the committee for diagnostic criteria met and in, of course, email communication and so forth. And Martin Turner wrote a paper, and the paper was published just last year, is diagnostic criteria, primary lateral consensus diagnostic criteria. So what happened is age has to be older than 25 and symptom progressive upper motor neuron, and the sign of upper motor neuron, at least 2 of 3 regions, and absence of sensory symptoms, and absence of lower motor neuron findings, and no alternative diagnosis besides PLS. And the diagnosis certainty is probable PLS, means 2 to 4 years. And then definite PLS is longer than 4 years after symptom onset. So I was a part of this committee, a part of the publication, but always I wondered what we're going to do less than 2 years after symptom onset. We have to do something about it. So these are papers before the meeting. About 2 to 3% of entire paper on motor neuron disease devoted to PLS, and rest are ALS. When you look at the PLS papers, most common is neuroimaging, clinical, and neurophysiology, greens and genetics, and neuropathology, cognitive testing, and biomarkers, and animal models. Those are papers. But if you look at papers, so few for ALS. Martin Tan and I wrote a preface for this supplement, and the supplement is published, and anyone can get these papers, and about 9 papers, including preface and the clinical spectrum, neurophysiological features, number 4, neuroimaging features, genetic of primary lateral sclerosis, understanding of neurobiology of PLS, and the neuropathology of PLS, which is very important paper by Dr. Mackenzie, and measuring PLS disease progression, how to measure the disease, and then clinical care and therapeutic trials in PLS. Those 9 papers into supplement was published. So another NIH review comment, they said a natural disease course has not been established in PLS. Is that true? We did some study ALS Cosmos, but well-established PLS cases. So PLS natural histories are so important to develop, but most studies are retrospective, means, as you know, if I have 50 cases of PLS in the past 20 years or 30 years, we collected the data, we looked, analyzed the chart, and extracted data out of those chart, medical record, and analyzed those data called retrospective natural history. It's very important developing new questions, but no one actually scientifically believe to use data for clinical trials. Yes, you can develop questions. One prospective study we did was ALS Cosmos, but relatively small number and well-established cases. That means more than 5 years, and because it is a rare disease, requires multi-site studies. Natural history is a prerequisite for us designing future clinical trials, because we have to know how disease progress, and we need to determine the best outcome measures, because we don't know what's the best. We developed the LSFRS scale, something like LSFRS, but that is really the best scale or something else, we don't know. We should be able to validate the reliability of new diagnostic criteria. Yes, we developed the criteria, but yet has not yet, it needs to be validated in the future. To improve understanding of PLS is very important through natural history studies. And if we can, we have to develop biomarkers for the future. And data will be shared by other investigators. This is studies. The key is to share the data. We are happy to provide all study data to other investigators for new clinical trials and whatever studies they have to, those should be shared. So we got funding again, SPF, ALS Association, Mitsubishi Tanabe, and MGH Neurobank supported the studies without charging data management, and also Mr. David Marin and family supported, and the Wings also supported these studies. So we assembled 31 centers, and I'm not going into all those names, but throughout the United States, you can see the happy face, so Northwestern, Midwestern, and South, and California, and the Canadian group, all joined these studies, and we just got the Northwestern first case and the Columbia another case. So we started the other case just last week. So we have standing committees, steering committees. We used just the first name, sorry, but several people function as part of a steering committee to steer the entire project and solve any unforeseeable issues of the problem, approve data and about sample sharing, and interpret the result and guide publication. That's what steering committee essentially run the studies. And the EMG committees I will talk about later, and the publication committee, and they not only look at the publication, but solicit publication. And the diagnostic validation committee means we have a new diagnostic criteria, and how good is criteria, they will determine this validation committee. So I have to tell you what inclusion criteria, and that so the participant has to be 25 and older, and the PLS diagnosis based on new diagnostic criteria. Symptom onset was no more than 15 years. So we can include anyone who less than 15 years, and ability to independently walk with or without assistive device. The reason is we have to check walking, therefore any device is okay, has to be able to walk. In cases where molecular testing is done, we have to exclude any abnormal molecular testing, particularly HSP, and expect to have at least some bulbar symptoms, such as even drooling, dysarthria, speech problem, swallowing problem, or pseudobulbar affect and forced laughing, crying. And but if they don't have anything, it's not excluded. But nice to have HSP test is negative. Upper motor symptom and signs, region other than legs, and it's important because if we include participant only leg improvement, high chance to be wrong with HSP. Therefore, arms at least involved 2 regions, and ideally some bulbar symptoms. Normal brain and spinal cord neuroimaging is essential, and no active major neurological disease other than PLS, and no history of a major neurological disease. And furthermore, inclusion criteria continues, no major unstable medical disease, but has to be old disease, okay, but recent medical disease. Residing within commutable distance, so they can come to the center. No history of ALS, PLS in immediate family, and no family history of hereditary spastic paraplegia. So we try to be clean, excluding all possible genetic contamination. No significant lower motor neuron degeneration upon EMG. EMG has to be available, done within 12 months. If it's not, we have to ask them to get a new EMG test, and we cannot pay because grant is limited, so they have to make a diagnosis as a new patient. Participant understand the purpose of the study and capacity to consent, and is willing to sign an informed consent form. There are exclusion criteria. Are willing, unwilling, or unable to give informed consent. Certainly, we cannot include those people. And upper motor symptom signs only legs is not a candidate. And unwilling or unable to visit the study sites are not ideal. And clinically obvious cognitive impairment will be excluded. And then participating in the clinical trials, whatever the clinical trial they are participating is not the candidate. Yet they can participate in clinical trials after enrollment we allow. So recruitment and enrollment early and the definite PLS. We are looking for a total of 100 patients, and we seek 50 early PLS. 50 early PLS means less than 24 months and after symptom onset, and only also including probabilist, that means less than 4 years. Why we include such early case? Because neurodegenerative disease, any neurodegenerative disease, I suppose, Parkinson's disease, Alzheimer's disease, ALS, all those neurological disease, the medication, if medication works, I believe, strongly believe, earlier the better. We start the medication early. So waiting for 2 years until becoming a probable ALS is not ideal situation. I want to include those early cases. So yet early cases are so rare, and I'm not sure we can get 50 cases even we have 31 centers, but that's what we have to take a chance, and hopefully we get sufficient number of cases. Now, 50 definite PLS means 4 years after symptom onset, we collect, and we don't have any, I don't believe we have a much problem to collect the definite PLS cases. In fact, although we hear many centers have cases to enroll definite cases. The problem is early cases. So what we do? So we do, of course, examination, informed consent, so forth, or site investigation, and then we try to get as much data through phone. Makes smartphone, using smartphone easier to evaluate, get the test uniformly. So we are using much telephone-based information, yet some has to be done at the site. For example, examination and breathing test, and also timed up and go test means those who sit and stand and walk 3 meters, coming back and sit down. So those has to be done at the site. Pen upper motor neurone score has to be examined at the site. And then we got urine, blood, and EMG test done at the 12 months point. So all others are done by phone. For example, cognitive testing and durable medical equipment and medication reviews can be done over the phone. LSFRS, which will be the key test over the phone. Pataka test means pataka as fast as you can in 10 seconds. And finger tapping, how fast you can do finger tapping. You can do smartphone and foot tapping. ALS quality of life test, LSAC-5, NeuroQOL, again questionnaire. ROSE test is a new test developed to LSFRS, will be done, and also and those tests will be done over the phone. So at site visit is baseline 6 months and 12 months at the end, and telephone visit is baseline 3 months, 6 months, 9 months, 12 months, and 24 months, just in case we want to make sure disease development over the phone, but not site visit. Again, I have to admit this is a shoestring budget, and try to be less expensive to do these studies. So these are proposed structures, and we have funding agencies. Columbia is a central coordinating centers, and we got IRB. Each center has to all IRB approval, and we have to get a subcontract with each centers, and steering committee oversight entire studies, and EMG committees evaluate also EMGs. 31 sites, all data goes to Neurobank. The specimen, urine, and blood goes to a biorepository, and we analyze all DNA for possible genetic causes and what harms will do. And urine oxidative stress biomarkers will be checked. All data comes to Biostatistics to Dr. Chan, and those data also feed back to Neurobank data source. And then diagnostic validation studies at the end, and the publication committee, and then finally we publish the data. This is the entire structures. So biostatistical analysis. So Dr. Ken Chan is biostatistician at the biostatistics department. He is currently acting chair of the department, and he's going to analyze all entire data characterize natural history of 2 patient cohort, as you know, early and well-established cases, and provide information future randomized control studies. So how accurately we can we use those data for PLS and upper motor neuron dominant forms ALS cases. So in many different features he's going to analyze. And the primary outcome, we decided to get LSFRS. And as you know, LSFRS, most cases are primary outcome in ALS, and survival also another primary outcome in ALS. So I hope PLSFR is a primary outcome we can use for PLS, but again, we don't know. We have another longitudinal outcome, such as PATACA, NeuroQOL, and other finger tapping and tag test and so forth. So those will be tested, which is more sensitive for the time change over time. We have a 3 site visit. We have a 6 phone visit. We all combined. Electromyography EMG test will be done at the 12 months. That will be the data to analyze accuracy of diagnosis. And the final data will be stored in Neurobank and again shared with others if steering committee approves. And biostatistics analysis, furthermore, we will have longitudinal data will be analyzed using a generalized linear mixed model biostatistical analytical method to look at the estimated decline rate. Every slope, how sensitively declining with less variable data. Less variable and steady change is probably best mark or best outcome. Also, we look at new case, early cases, and well-established cases may have a different progression pattern. We may not be able to combine 2 cases. Yet at the same time, we can combine if the disease moves same speed, we can combine. So we have to see. Also, we have to see any difference in terms of age, older age, younger age, and onset cognitive testing, any other clinical compounding factor and affect outcome data. And also, we must have good data because we don't have any missing assessment. More missing data are present, the data will be the poorer. So we have to get good data to obtain. And specificity of updated consensus diagnosis will be tested after 12 months using EMG and clinical findings. So it's a lot of things we can analyze, a lot of data will be collected, and a lot of scientific publication outcome and hopefully influence the future PLS studies. So data management will be done in Neurobank, as I said, generous support by Alex Sherman for these studies. And then EMG committees, these people, Dara Heitzman, Eric chairs along with other people. And what they do is they are going to review all EMG studies available at the enrollment. They have to say acceptable and so forth. So first approval I have to make as a PI, yet all EMG forms will be approved and evaluated by EMG committee. And also they decide which muscles to be tested. We use the same muscle so we can compare every patient in the same way. Currently EMG done by EMG doctors decide which muscle is the best. But for this study, same muscle will be tested. And also how we complete, how we generate study analysis and data will be defined. So we will have uniform EMG data at the end of the study. These are muscle decided, and tongue, biceps, pronator, first DI, and thoracic paraspinals, vastus naturalis, tibialis anterior, medial gastrocnemius, and sorry for so technical terminology, but all same muscle will be tested entire patient, which is extremely variable data because currently EMGs, as I said, so variable muscles tested. So Diagnostic Validation Committee is another very important, interesting study they plan. And Lauren and Miracle are chairs with rest of committee members. What they do is how new diagnostic criteria is validated. So they, at the end, they looked at the data, evaluated, including EMG data by 2 independent committee members assigned. And if they got the same conclusion, conclusion, they that's fine. But if they disagree, 2 people disagreed, we'll have another third person will be referee and decide what's the best way. So we will have a consensus diagnostic final diagnosis and compared with the first diagnosis, so we can validate how good when we make a diagnosis 12 months before and 12 months later, maybe 90%, maybe 70% diagnosis is the same. And also we know something issue is there at the end enrollment. EMGs, weak EMG showing some possible determination turns out to be not the PLS in 1 year, kind of scenario we can make. So we can further define, we can make better diagnostic criteria based on this result. I hope you understand, if you follow me. I hope I explained better, I hope. But anyway, this information will be used by a biostatistician, Ken Chang, to calculate the sensitivity of the criteria as I mentioned. So this is a very important studies. Publication committees, Christina and Sabrina Paganoni will chair the committee, and how they do it, and they have to read all paper and approve. And also we have now how we define list of public authors, and authorship is a very sensitive, important issues, but my key is inclusive. Everyone involved has to be part of author, if not, has to be expressed in authorship. And also publication committee solicit some interesting future papers. Publication committees steer the future publication. So natural history studies initiation and training conference already done in July, and Madison and Grace did the training session in July. And after July, we have now monthly conference call with all site going over what's going on, where is their status, IRB approval, subcontract, where they have new patients and so forth. We go monthly. So another NIH comments I learned is what's the issues. They said currently no medication to investigate in PLS. They are right and they are wrong. For example, we have 2 approved ALS medication, Riluzole and Radicava, Edaravone. And those medications, if someone wants to try, if someone has PLS, insurance will not approve. And medication is still very expensive. For example, Radicava costs $130,000 or $180,000 a year, so expensive. And certainly no one can afford paying medication. And you cannot say the patient has ALS if they have PLS, which is diagnostically very different. So testing currently available ALS medication is in the future is very important, if not Riluzole and Radicava, but newer medication approved, it should be tested in PLS, and we have now method to test through this natural history studies. Also, several medication on the horizon is a very, very possible another third or fourth medication becoming available very soon, and those medication actively investigated for PLS. And then, as I mentioned, Dr. Oslinger, and the first name is Handy, is now, she said, has a new medication exclusively working for upper motor neuron. Those medication has to be tested exclusively patient with PLS. So in fact, medication becoming available for future investigation of PLS. So serious concern about the execution of PLS natural histories I have to. So we got approval more than almost 1.5 years ago from PLS, SPF Foundation, SPF, and ALS Association, and all those grant approved early 2020. Now, October 2021. And now we are enrolling a patient, starting enroll a patient. I'm very concerned because this, I have to admit, crazy number of multi-site studies, 31 is a huge number, and making each informed consent approval, IRB approval, subcontract with Columbia Universities, I have to say, nightmare. It takes such a time, and furthermore, COVID slowed down everything. So we have to have certain operational costs to keep going. We cannot stop operation, for example, supporting coordinators, studies. We cannot stop, and certain things we have to keep paying. Yet the patient's not enrolled. So I will have big trouble, and I need your understand and support for the future. But I think once a patient enrolled, we can keep going, and so that is a major concern. So I am coming to summary and conclusions. PLS has been rare, enigmatic, neglected motor neuron disease, but not anymore. I think PLS is now different, and something we are investigation. We can investigate the disease, we can learn, we can do clinical trials. International investigators, disease organization have finally and recently paying serious attention to PLS. International conference was held in 2019, and in fact, a lot of funding agencies, including ALS Association, NIH and so forth, funded. That means they have a serious concern about PLS. PLS specific functional rating scale has been already developed. New PLS diagnostic criteria has been published. It's a major progress. And the HSP PLS Canada has been established recently. And the new upper motor neuron committee, and also more advanced neuroimaging studies are started again, funded by SPF, which is very important, making further progress. And the multi-site extensive prospect PLS natural history is now underway. So this will be the key for future studies funded by several organizations. And the clinical trials of PLS are becoming reality for the very near future. As you know, PLS has never been included in ALS clinical trials because the disease may be different and disease is too slow to include ALS clinical trials. But now PLS becoming independent disease and amenable for future clinical trials. So thank you very much for your attention, and so I'm happy to answer any question. Once again, really appreciate to Spastic Paraplegia Foundation, the continued support and their commitment for PLS research. Thank you very much.
Thank you very much, Dr. Mitsumoto. You have several questions.
Okay.
The first one is from Hank Chupi, and he was saying, has any of the patients tried Keppra? And there's a Facebook group that records their symptoms and progress. And he said Dr. Bedlock did a small study about it. There is a Facebook group where people share their reactions to the drug. Not all patients get a positive reaction to Keppra.
So I have to admit, I do not know all well about the Keppra, but the Keppra is anti-epileptic medications, and anti-epileptic medications may be beneficial for controlling hyperexcitable motor neurons. That means spasticity, hyperreflexia, and those upper motor neuron manifestations. Theoretically speaking, Keppra might be beneficial. Keppra is relatively benign medication, less side effect, can be tested. But again, I cannot tell you, always those small number of clinical trials we deal with anecdotal experience. And if a patient who tried on Keppra and noted significant improvement, may be good reason to try formally clinical trials. So again, PLS is such a rare disease, and as you see already, we had 31 centers working with 100 patients for a couple of years, or I hope. And so the do clinical trial is costly. Time, it requires a lot of time, a lot of centers, a lot of cost and tests. So we have to test the medication, which is very likely to give significant benefit for the patient. And so the two clinical trials, one is symptomatic treatment. Symptomatic treatment for PLS is stiffness, a walking problem, and we call the spasticity. Those are main disabilities. Those symptoms relieved by medication such as Keppra, which is great benefit for the patient. The other medication is disease-modifying medication. Disease-modifying medication means working somehow, pathogenesis means the cause of the disease, and disease and directing to the mechanism of disease and delaying disease progress. That's what the disease-modifying disease. And so we have yes and no kind of medication yet. So we have to find out which way, completely open, if we have good symptomatic treatment, which is very, very beneficial for the patient, because patient functional disability will be improved. So either way, we have to do clinical trials, but always clinical trials, the beginning, patient experience is the beginning of the clinical trials. And probably some of you know medication called, I'm not trying to advertise, but medication called dextromethorphan and quinidine combination called commercially Nuedexta. Nuedexta is good medication to control forced laughing, crying. Patient may have just quickly a little bit of little things going into giggling, smile, laughing, or crying phenomenon, which is very socially disabling and embarrassing. But this is actually very interesting histories. When Dr. Smith, Richard Smith, did the clinical trials dextromethorphan, and dextromethorphan ALS was negative. So he tried to close the studies, and several patients came to him, please don't stop the medications because my laughing or my crying stopped with this medication. So usually maybe you dismiss those comments, but Dr. Richard Smith, that's something strange, something interesting. Maybe this medication may be beneficial for stopping crying, forced crying called PBA, pseudobulbar affect, and he wondered. So that's the reason, the beginning of new studies, and turns out to be this is beneficial to controlling PBA. So patient experience and telling the doctor this is beneficial and so forth is a starting point for new clinical trials. So if in that case, if Keppra is beneficial for reducing spasticity, improving the walking and so forth, it could be medication need to be tested.
Okay. Dr. Mitsumoto, we have had several questions, one of which is from Karen Howard, and she says, I believe digestion issues vary with distinct differences between PLS and ALS. My neurologist asked about incontinence, but I didn't ask why. Is it generally a muscle issue? And then Hank asked kind of the same thing. How are internal organs like bladder and diaphragm, etc., affected by long-term PLS patients?
Now, would you tell me, Tina, at the beginning of a sentence, what did you say beginning?
We have had several questions about, I believe, digestion issues vary with distinct differences between PLS and ALS. Is it a muscle?
Okay. Digestive system. Well, that area is, I must admit, least studied. And I have to admit, we don't have enough information. However, constipation, I'm talking about now ALS. I do not know anything about the PLS, but talking about the ALS, constipation seems to be more common in ALS than other healthy people. And also the time of symptom onset, the constipation seems to be getting worse. And also one study investigated how our intestine guts moves, how things are moving from stomach to intestine to bowel, and how long does it take to eating to making final stool formations. They looked at the passage, and apparently patient with ALS seems to be slower, significantly slower than healthy people. So clearly digestive system is impaired. Patient lose appetite, whether because of depression or some other cause may be causing lack of appetite, yet might be something to do with intestinal movement, gastrointestinal movement. So digestive system is least investigated. Now, also you talked about bladder function, and we studied and we found out with surprise, PLS patient can be divided into two groups. One is urgency and also frequency, unable to hold urine. And the other patient group is no such problem. Seems to be dichotomized, seems to be two groups. Whether this has something to do with the disease progress, disease cause, disease process, we do not know. We need to have more study, and I hope we can study with the current natural history studies, we can say those findings, but at the moment, we don't have enough data yet. Generally speaking, we say to the patient, and motor neuron disease has generally completely normal normal internal organs, normal heart, normal digestive system, lung, and essentially problem is coming from muscles. Yet, on the other hand, I'm talking about ALS. ALS is probably systemic disease, a metabolic systemic disease. Somehow, other organs might be involved, but still we don't have enough data. We know lipid metabolism is abnormal. We know homocysteine metabolism abnormal, and many biochemical abnormalities is recognized in the patient with ALS. So might be something going on. It is possible, PLS the same way, just not enough data. I hope I can answer your question.
Okay, then James Fitzgibbons asks if there is any good exercise or stretching routine that you could recommend.
Yes. So I'm not a physical therapist, but I tell, probably everyone knows, if you don't move, if you sit in the movie theater 2 hours, just straight and watching TV or watching movie, when you try to get up, you feel body is so stiff. So I think it's very important. Of course, you cannot do exercise during sleep, but waking hours, you do probably every half an hour. Move your body and whatever kind of imaginary aerobic exercise, arms, legs, like bicycling. When you're sitting, move your leg, doing some bicycling in the legs. Only you need a half minute or 1 minute. Even shorter period, moving body frequently is very helpful to prevent stiffness. And of course, range of motion is so important. Think about where is the joint, neck, shoulder, arms, wrist, fingers, and hip, knees, ankles. Joint has to be all range and all range. So moving, think how your joint moves. So stretch exercising, ranging motions, at least twice a day. It's a good stretch exercise is very important.
That's very good. Rita Handrich asks a question. She says, I had genetic testing, including FLAS variants.
Which test? Sorry, which test?
FALS variant about 8 to 10 years ago. My neurologist tells me there is some research that where I can be gene tested again. Are there genetic results that would make this worthwhile for me, having been already tested but unaware if there were any new gene errors that might be discovered? Or should I let another untested PLSer have the slot?
That's a tough question. I'm afraid I cannot answer, provide a good answer yet. Best way, if the test done several years ago, yes, the molecular testing, genetic testing made incredible progress. And so better to ask genetic counselor at the centers if is a good reason to test once again, because now we do not the genome, but the exome sequence, all potential pathological genes we can screen much better way and cheap way and fast way compared to several years ago. It's just progress in this field is just incredible. So first, I think you should ask the doctor, the centers, and genetic counselor is probably the best way with those report.
Okay, Jesse Devine asked a question that I have had too. Do you have a link to access the various papers published in the connection with the 2019 PLS conference?
Yes, yes. You have to go to PubMed. Everyone can go to PubMed. Access PubMed, P-U-B-M-E-D, M is capital, PubMed. You can Google, you can get the PubMed, you can go to the site, and then you can go to, there's a space, you can type several words, PLS. Best way is primary lateral sclerosis, spell out, and has to be capitals, and A and D, then PLS. Then you can get all paper published for PLS. So you can share my slide with people, and you can go to the first author, whatever, Mitsumoto or Mackenzie, whoever published. You can go that papers, and paper is available without a charge. It has to be open access. So usually publisher try to support their publishing right and the cost. So they charge you $20 or $30 when you get the paper. But with those supplements, the paper is free, open access. That's the way, is the best way.
Okay, well, thank you. Is there a way that we can get a copy of the LSFRS, maybe from SPF? Is there any benefit to keeping our own records or any preliminary studies using self-assessment?
Well, obviously, LSFRS is available if you go to a journal called Muscle and Nerve. Again, you can go to PubMed and Mitsumoto and type PLSFRS. You can get that paper. And I'm not sure this is open access or not. If it belongs to university, is easier. But if you cannot get it, let me know. I'm happy to provide. But if you can share the slide, that would be okay.
And Dr. Osdenler wrote in a couple of questions, and she says, yes, we would love to develop a U9 treatment strategy for PLS patients. These developments are amazing. So thank you, Dr. Mitsumoto. And she says that it was an amazing seminar. Your lifelong contribution will soon help and end PLS. These are challenging and exciting times. So she goes on to say, thank you, thank you, thank you.
Thank you very much for kind words. Really appreciate it.
Okay, next we have Stephanie Havelka. When will you recruit patients? I am a New Yorker with probable PLS. I'm only 46. My symptoms started 3.5 years ago, but diagnosed with probable PLS. Only in March 21st. Moving for work to Dublin on November 1st, but would like to participate.
Surely, I love to see you, and please email me. My email address I can tell you, hm264@cumc.columbia.edu.
Anthony Morali said, is there any studies and or medications currently for HSP? Well,
Well, that is a little bit, I'm sorry. I probably better to ask Dr. Fink,
Yeah.
and he is truly guru of HSP, and you have to ask him. I'm sure now. I have to tell you, genetic disease is making incredible progress. And the best story is SMA. The infant born with SMA dies within 6 months or 1 year. Terrible disease, but now they can live.
Yeah.
They even become able to walk with medication because we know genetic mutation. We know we can not correct, but we can go around different pathway to provide better material. So block bad genes and making a better one. So we can make disease better. That's the best example. And now we have a great hope. Many genetic mutation, we can do something. So I think it's. I have not been in other neuromuscular disease such as facioscapulohumeral FSH dystrophies, Duchenne dystrophies, limb-girdle dystrophies. I used to see those in the past. And I'm not up to date. I'm not sure I know everything in those areas, but just recently I just covered a doctor who cannot be MDA clinic, and I learned so much now. The new treatment becoming experimental, clinical trials going many different directions. So I'm not surprised if Dr. Fink will tell you new treatment is a plan and so forth. Experimental though at the moment.
Mark Sturman says, my neurologist suggested a baclofen pump to help with spasticity. In the trial to see if it would help after an injection of baclofen into my spine, I became paralyzed for a few hours. No one had seen this before, so they tried it again with the same result. Have you ever heard of this reaction?
No, but it can occur because too much baclofen make muscle weaker. So the balance is the key. You need some dose to make muscle less stiff. But even oral medication, if you take too much oral medication, muscle becoming weak. So weakness and stiffness is a continuum. And so if you use medication too much, muscle becoming too weak and really paralyzed until medication wearing off. And that is kind of pharmacologically expected, but again, you titration, what's the dosage and so forth is key. That's all I can tell at the moment. It's a very, very, very balanced. Also, it is some people are more sensitive to medications, and so regular dose, which okay for other people, may not be okay for that particular person. So titration, right titration is a key. That's all I can say.
Okay, Dr. Osdinler has put a couple of links to your paper and the PLS in the Q&A. So I am just telling so that everybody else can look at that and see the links. Stephanie Havelka says, yes, this has been a wonderful webinar. Appreciate all your hard work, and we'll be contacting you via email. Kudos for doing a multiple site work. I am a scientist myself, so I know the headache of funding IRB study. IRB, etc.
Thank you very much for sharing frustration. Thank you.
Dr. Osdenler says, Dr. Mitsumoto, do you think the clinical setting and outcome measures you develop can also be utilized for directed gene delivery studies for PLS patients in the future? These will be personalized medicine approaches.
Would you say it again, once again? Would you read it again?
She says, do you think the clinical setting and outcome measures you develop can also be utilized for directed gene delivery studies for PLS patients in the future?
I think so. I hope so. As you know, I already told LSFRS is universal in terms of ALS communities. ALS clinic, patient care, clinical trials, basic researching with the patient, everyone, really everyone using LSFRS. Any clinical trials, doesn't matter, molecular testing, gene clinical trials, and antisense nucleotide infusion and so forth, all those clinical trials, they use LSFRS. If PLSFRS, based on our study, turns out to be good scales, I hope everyone can use PLSFRS. But again, I'm open. Better scale, something better can be developed out of this scale. And so I think science has to move to the better direction.
Kevin Gallagher said exactly what I've been thinking too. And I'm sure a lot of people that are listening today are saying this. I'm interested in enrolling in your study.
All right, great. I don't know where do you live, but there are so many centers in the United States. Hopefully you can call if you let us know. I'm happy to guide you where you should go. Thank you very much for your interest.
Okay, and just one other question. I had the injection in my spine. I could not walk at all. I went no further. So there's another person that had the same reaction.
With microphone.
Yeah.
Can happen, right?
Okay. Are there any more questions? So I see. Yeah, I think that's it.
Okay.
I want to thank you so much, Dr. Mitsumoto. I have learned so much and it's so promising. I mean, I'm very excited about this. Okay, Norma, can I pass it over to you?
Thank you very much, Tina. Thank you so much, Dr. Mitsumoto. We greatly appreciate all of your presentation today. This has been fabulous. You've had great questions, a lot of interest, lots of information. So on behalf of everybody on the computer paying attention to what you're saying, we want to just give you a great moment of appreciation. So thank you so much. Remember to save that date that I gave you, and I'm going to be telling everyone so that we can see you in person, Nashville, Tennessee next year.
I'm looking forward. Thank you very much for this opportunity once again. Thank you.
Thank you, sir. Take care.
Bye-bye. I'm going to
Bye-bye.
Bye-bye.
Thank you, sir.
Thank you.
Well, as you guys see, we have got our survey poll that is up this afternoon, and I want you all to take time to go through all of that. Be very nice and generous with your information and sharing that for us. We want to make sure that we're providing to you the best information that we can. We want to make sure that you guys are able to get your questions answered and that we can find out the very best information that is absolutely available and on the cutting edge for all of us. There's some information that I want to share with you. And really what I'm doing is kind of giving you a little extra time to answer the poll that we have, because that is really helpful for us. So if you guys have some, constructive criticisms, then we certainly want to take all of that into consideration. We are not restricting anybody from being able to see the information and be able to access. So if you are having problems getting on, it's probably on your end with technology. You know how that works. But I do want to share some information with you that once this video has finished its recording process, and we've gone through and kind of changed all of the things that we need to in order to get that uploaded, it will be on our YouTube channel. So please go back to, you know, the foundation's website if you're having problems trying to find it on our YouTube channel. Make sure you bookmark that next time you do find it. But we, as soon as we are able, we will have that information uploaded so that you can review all this information. We will also provide you with all the information that we can so that you can get back with Dr. Mitsumoto. I think I did type in the chat box his email address, but we'll make sure that we put that on his video as well. So, you know, please reach out to him and see what might be available as he talked about the different kinds of studies. I'd like to point you again back to our website, which is sp-foundation.org, because on there you will see the current studies that are seeking participants for some of the things that, you know, you guys are interested in and what we need to know about it. We need to, you know, have everybody involved in the information so that when the doctors, you know, are asking for people, we know how to get a hold of you. So, you know, go to the website, sp-foundation.org, and under the research tab, you're going to see all this information that he shared with you, and you're going to be able to find that information, and you're going to be able to see all the details and how you need to get involved and get started in seeing if you have this location, you know, near where you live, where your homes are. So please go there, check that out. There's some other information about clinical trials that you might want to touch base with. But then, you know, as I'm talking to you about this, we shared this information to you in emails and on the newsletters, whether it's electronic or whether it is the printed version, which you can also get on the website already on there. So just download that information. That'll save us that postage. But please go and make sure that you join the foundation's membership. It's a free membership. Again, go back to the website, sp-foundation.org, and you will be able to join our foundation information, which will gain you access to all the information that we're talking about. And then you'll be able to receive those emails from us. So make sure you have checked the boxes in those categories so that you can have that information. Also, I wanted to tell you about, as I was talking to Dr. Mitsumoto, in July of 2022, we're going to have another in-person conference, and this year it's going to be in Nashville, Tennessee. So pretty soon we're going to be having the little teasers out there for save the date, but I'm going to go ahead and tell you now, save the date is going to be July the 22nd through the 24th in Nashville. So as soon as we are able to get all of the details worked out for the guest rooms, the hotel, you know, the agenda, you know, all of that kind of information, we're going to get that out to you just as quickly as possible, and you'll have all that information. So when you look at Facebook, you're going to find it on the website first. So go make sure you're joined to the foundation and not just to the Facebook pages, because not all the information gets shared out on Facebook and it doesn't get to kind of make the circuit. So we want to make sure that everybody's going back to the website to get their information from there first. So again, it's going to be starting like Friday morning. So if you need to make arrangements to get to Nashville, please understand that we're planning for the agenda to start like on Friday morning, and it will go into like Sunday afternoon, like at noon. So just kind of be on the lookout for that. But again, that's July the 22nd through the 24th of 2022. As a reminder, we still have that poll open. So we want you guys to be looking over there and how you need to complete the poll so that we can kind of wrap up what we're doing this afternoon. I also want to tell you some other very important information, and that is we have another HSP doctor from Brazil that's going to join us on November the 13th. So please make sure that you go back to the website and register for that. And I want you guys to understand that we're putting in new registrations so that we can protect the security issues that may pop up on, the Zoom platforms and all the platforms. We want to protect the information of our population. So make sure that you always go back to the website and register again, and that you're not using these old login codes or these old links, because they're not going to work. But surely you know that by now, because the next one's going to be our number 7 in the series, which will actually wrap it up for the year. So I'm hopeful that you all have been able to enjoy the information that we've provided to you. It has definitely been a challenge to deal with new technology and new changes, and to get everybody kind of on the same page learning the technologies. I am hopeful, and I'm not saying this is going to take place exactly just yet, but I am hopeful that we are going to maybe have the ability to do some live streaming at the conference in Nashville. But we certainly don't want to take away from the fact that we really want to see you there in person, and to enjoy the camaraderie that we have with everybody that comes in. So we're going to be, having some additional information available whenever we get a chance. So I think I've kind of touched everything. We will again provide this information in this complete video in its entirety on our website. And if you haven't had a chance to see that information from all the past doctors that we've participated with, then those are all also already on our YouTube channel. So, as soon as you guys see that, it would be helpful if you would share that link on your social media page, which would then give us an opportunity to gain more followers on our YouTube channel. So I'm about to kind of wrap up. I hope everybody is ready to end this. And again, I want to reach out and say thank you again, even though I think he's already left our conference. I want to thank you, Dr. Mitsumoto, for joining us today. And thank you for all the people that are in the back office, making sure that technology works. Thank you, Frank and Tim and Hank and Tina, for all of the things that you guys do to make this a wonderful, successful webinar series. Again, save the date, November the 13th. Our next Brazilian doctor will be joining us that day. We'll be putting some more information for you to register on the website under the virtual webinar series. So that's the bell. Time to go. Thank you guys so much, and have a great afternoon.